Maybe just a brief comment before we start with our MSc session. At the end of the previous session, I made a comment on thinking about what kind of therapies patients should have received before they are eligible for stem cell transplant. At that time, I only mentioned the IL-18 binding protein antibodies, but of course, we have discussed a lot about interferon gamma inhibition, and that's as valuable as the IL-18 binding protein. So I meant novel therapies and not specifically only IL-18 binding protein. So that, having said that, I think we can move on to our next session, which is on mesenchymal stromal cells. And we have two speakers. One is me. Nora Singer is the second, and I think we have a nice set of experience. I will very briefly introduce the concept, followed by our animal work and our preliminary data in 5 patients with refractory JIA. Okay. About MSCs, it has been stated already very briefly that classical stem cell transplantation with hematopoietic stem cells can be very risky. Instead of that, mesenchymal stromal stem cells have been used as immune suppressive cellular therapy. You have to realize that this is very standard, well, not really standard, but it's applied a lot in allogeneic stem cell transplantation where patients suffer from GVHD grade 4. And I think I lost track exactly, but at least 3,000-4,000 of such procedures have been performed in the past year. So it's very commonly done, and so there's a lot of experience when it comes to dosing, repeated dosing, and safety especially. And in general, what we do in the human situation, that we use MSCs only after a limited number of passages, because in the animal work, when you did multiple passages, there was a possibility of chromosomal abnormalities in those cells, and to avoid this, for safety reasons, this was completely changed so that we only use second or third passage cells. So that's an important thing, I think, also for regulators. And all programs that use mesenchymal stem cells for use in humans use this technique. So with that having said, I think we can continue about the MSCs themselves. They are immune suppressive. They can be given as a on-the-shelf product. They have a very weak expression of MHC molecules, and they can be given without any similarity. So you can give them from a completely unrelated donor. And that's very, very practical. As I said, we have also given MSCs in children. There are several programs you heard from London also, where MSCs are being given to children in similar dosages, and also there is no toxicity or safety concern so far. So how did we test those? This is our model showing proteoglycan-induced arthritis model, which is a nice model to study chronic arthritis. Here you can induce the arthritis and also manipulate the mice in order to see if the intervention has any effect on the arthritis. It is very progressive and chronic and erosive, and therefore it resembles chronic arthritis very well and can be studied here. And in view of time, very briefly, what we did is we gave the mouse intraperitoneal but also intra-articular injections with MSCs. And this is the normal POW. Here you can see the effect after induction of arthritis, and it can be completely, as you will see later, blocked by MSCs. This is then showing the scores. The mouse were scored double blind, so the scorers were not aware of the injection that the mouse received, whether it was sham or it was MSCs. And you can clearly see that in the MSC treated mouse group, there was a much, much lower arthritis severity score. And after the scoring, the mice were sacrificed, and here you can see the histology showing that, in fact, we had a very normal histology compared to a normal knee, and this is the knees that were not treated with mesenchymal stromal cells.
These are intra-articular injections?
Yes.
And no systemic injection?
Say again?
No.
There were several groups. But the histology was the same. There was intraperitoneal and repeated intra-articular injection.
Two different groups, or?
Two different groups. But the histological and clinical effects were similar. Surprising, yes, yeah. After there were repeated intra-articular injections, and after the first injection, the effect was somewhat suboptimal, but after the second injection, it was completely similar to the intraperitoneal injection. So these results, they were performed by Joost Zwart in our lab, and he published this in 2014, and he concluded that there were clear beneficial effects in both routes in this animal model. At that time, we could not find MSCs to migrate outside of the injection region. We have the idea that they act through regional lymph nodes and spleens, but it's very difficult to prove this, the presence of these cells, because they work in a hit-and-run fashion. Very shortly after injection, they are being killed by the immune system of the host. After that, they have exerted their immune suppressive action.
You didn't see any cells in the lungs?
No, indeed. In animal models, when you treat animals with MSCs, they're very large, sticky cells. You can get very severe asphyxia, especially in higher doses. This has never been seen in humans. So, of course, we were worried about that, and that was initially the reason to look for intra-articular therapies. But this has never been observed in the GVHD treated humans.
But there are trials of MSCs in ARDS where they're actually seeing, basically expecting the cells to help the lungs.
Well, if you give them IV, of course they pass.
But are the effects paracrine effects from cells? Like, or do you have the cells to be homing to the joint, or is it paracrine, given that we have similar effects with the systemic administration as the local?
Well, that is the idea that probably in a paracrine way that anti-inflammatory cytokines are being produced. Yeah, yeah. Difficult to prove. Yeah. Yeah. Okay, then this was our initial plot of investigations, and suffice to say that we planned before and after MSC injection in children. We planned a series of MRIs as well as arthrocentesis and blood sampling before and after the MSC's injections. In total, it was possible to give 3 injections. This was the program that was submitted to the IRB, and it was completely crushed by the IRB. And note that this was protocol. We received a grant from the NIH, so to say, the Dutch NIH, for this protocol. But our local IRB demanded changes that we had to fulfill. And they said it must be a safety study first, and since there is no experience with allogeneic MSCs in joints, there is a lot of experience with allogeneic MSCs for GVHD, IV. They said, well, why don't you try adults with RA first, or switch to autologous MSCs? That was their comment. And they also asked whether MSC injection in growing joints was really safe. There was maybe a concern that MSCs could differentiate in osteoblasts and produce ectopic bone formation. This has, to my knowledge, never been seen in children or adults. And of course, is the burden of all our investigations that we put upon patients and parents not too high. So we had to come to a sort of compromise. The study was amended significantly. We sticked to the allogeneic MSCs. That was accepted, but we switched to the IV mode. This was also effective in GVHD children, so we thought, well, we can live with that. We had to skip the arthroscopies, so we do not have pathology. We cannot do chimerism studies, which is of course too bad because we cannot track the cells, but we were allowed to do, of course, clinical follow-up and repeated MRIs. And with that setup, the IRB approved the study, and since then we have done 5 out of the total 6 patients. Number 6 is being prepared for the next few months. The inclusion criteria were not just systemic GIA, but in fact refractory GIA of any subtype. Yeah, despite, of course, therapy with 1 or 2 or 3 biologicals. In fact, any biological that was registered for this subtype. Exclusion criteria were refusal to withdraw the biological prior to infusion, infection, malignancy, and pregnancy. So, as I said, we've done...
You actually took them off the biologic drug that they were on?
That is correct.
That's amazing.
Yeah, but it was not effective. They had ongoing the disease. So, yeah. Yeah, and then we said, well, we see very quickly if it works. It's a very short procedure. It does not require conditioning like allogeneic SCT. So, you know, you wait a few half-lives of the drug, and then you can do this procedure.
So you withdrew biologics, what about DMARDs? Did you allow them?
Continued, yeah. Methotrexate was continued, and low-dose steroid was acceptable. Of course, you don't want to induce MAS features by stopping the steroids too quickly.
Any concerns about possible effects on the survival of mesenchymal cells?
Well, from the top of my head, we had only patients with very low dosages of steroids where we were not concerned about this. Yeah, and 3 of them, there were no steroids at all. So there were no adverse events seen. This is an example of such a patient where you can see, well, you recognize it. This was in fact an extended oligo patient, very resistant to all available therapy, had ongoing inflammation and well, very damaging erosions of both hips, and we fear that this girl was going to be severely invalidated by this disease course. So when we showed on MRI evidence of ongoing inflammation, we included her into this study based on methotrexate therapy only. This is another patient, a boy 9 years old, difficult to classify. There is a history of fevers early on in his disease, some exanthema, but it was difficult to really ascertain this. So he has definitely polyarticular course that has been treated with a variety of drugs. I think we take him as a systemic onset patient based purely on the story of the parents. But it was not nicely spiking fever. There was some, undulant fever. There's some rash, but it was quite vague, and it was a long time back already. And he has very severe crippling disease that can only be controlled by corticosteroids. In fact, such a patient is also eligible for our current SCT program for allogeneic SCT, but parents are very hesitant to go along with that. So, and as I said, he had prednisone in a low dose of 10 milligram daily. So then the other patients is a bit similar, with a very long disease history, where we tried a lot. He even had in another country, he had an autologous stem cell transplantation where he responded very favorably to, but he had an early relapse already after 3 months that could not be treated, and he was then referred to our center for MSCs, and he received also 2 infusions. And then very briefly, because this is a toxicity study, right? Safety. And there are so far no safety concerns. We were allowed to look at efficacy, which is of course for us quite interesting. It's open label, of course. This is looking at well-being. This is a functional scale. This is the physician global, where you can see that we have the impression that there is a more favorable course of the arthritis after the infusion of the MSCs. This is active joint count. This is what we now call the composite scores of JADAS, and this is ESR that shows a tendency to decrease in most children. This is the MRI score, which is quite difficult to score. MRIs. It's a short interval, right? And also there's quite a lot of erosion already present, because it's an illusion to include only patients with marked inflammation without any erosion at all. So this is what you have to live with. But the MRIs were blinded for the radiologist, and this was the score. In fact, that there was a tendency of less bone marrow edema, less synovial enhancement, and less cartilage loss. But these are very early data. I mean, this is what it is, and of course we have to wait longer follow-up to see if this really substantiates. And but so far, I think we can conclude that the MSCs appear to be safe, might have a positive clinical effect, and also reduce the cartilage loss. Yeah, the thing is, what is the future? Because these are very costly studies, and at this moment, I'm not sure how to proceed into a phase 3 study, because putting many patients is not going to work, and we can never have funding for that. And I think the better option would be to increase the sample size and to continue in this way that we are doing that, and by really closely looking with MRI and as well as blinded clinical follow-up, we should be able to get some answers for these questions. And that's about it. This is the Dutch team that's working on it. And this, I should say, this is funded by the Dutch ZonMW, which is the Dutch NIH. Thank you very much. Oh yeah, lots. I could not specify here. Of course, we sample lots of blood, and we do the Luminex and all that, and the S100s, and this is all in ongoing research. Yeah.
The MRI data suggests some cartilage recovery, actually.
Yeah, wait and see. Yeah, it's set. Yeah, that's correct. Yeah. But I'm still, cautious.
Can you talk about the dosing? Like what was the amount of MSCs that you gave the patient?
Yeah, that's an interesting question. Do you know how we come to dosing? We use 2 million per kg. Do you know why? Do you know the history behind this? Did you think we did a dose escalation curve? Who knows the answer to this question? Alexi. Katrina Leblanc, she published in Lancet 5-6 years ago a patient with leukemia that was treated with stem cell transplantation and had very severe grade 4 GVHD. And then they decided to give MSCs from father or mother, I forgot. And this was just the dose that they had. And they calculated it, and this was 2 million MSC per kilogram recipient. So since then we stick to that dose.
Everybody sticks.
Yeah, worldwide. Yeah.
Yes and no. And sort of this dose compared to what you did in your mice, is it comparable?
Yeah. I think in the mice it's a bit higher. Yeah, but it's comparable. Both, yeah. We had different groups. It's published in Arthritis and Rheumatology, so you can see all the details. Yeah.
Nico, as you can expect, I have no scientific question. I've quickly searched our website. There are 3 PIPs for MSCs and 11 orphan designations for anal fistula and a lot of other diseases. So my question is, do you have any plans to develop this medicine towards authorization? Do you have any regulatory plans?
Well,
because obviously
that
there
would
are
be
companies
fantastic.
developing
I mean,
this product.
this is of course, the ambition, but we would have to look for a way how to do this. But first, expand our experience. But that,
ideally, before embarking to phase 3 study or even phase 2 study, there should be a pediatric plan for a developer. Of course, for academia.
So then you're going to help me with it?
Well, as far as I can, of course. But I mean, there are companies developing the product, obviously, who applied for PIPs already. So why not to collaborate with them?
That's a good suggestion.